All right, welcome into this very special episode of Live Pod Patrol Podcast with your host, Dr. Jeff Dykes. I am joined by two very special guests, Dr. Tom Chang and Dr. Luke Cicchinelli. Thank you for joining us.
Thanks for having us.
Yeah, it's wonderful to be here. Thank you, Jeff.
Absolutely. We are coming to you live from the Des Moines Heartland Podiatry meeting in Des Moines, Iowa. And we're just happy to have these esteemed guests here with us. This is a non-CME sponsored event by Ossio, a company that we're going to dive into and talk quite a bit about today. But that is an important clarification. This is non-CME. So we are going to talk about this product, this company, and what it's meant to you moving forward. So as usual, if anyone listens to the podcast, we're going to jump into the intro video. Alrighty, I'm joined by Dr. Tom Chang. No introduction needed. Luke was gracious enough to jump on here with us, so we're going to jump right into the concept of what we're talking about here, which is Ossio. Tom and Luke have been using Ossio now for how long have you been using Ossio?
I would say probably around 4 years.
And Luke?
Well, we started in Spain in 2016, where I did the surgeries that were the initial part of the clinical trial. So 2016 or so was the beginning of it.
So when we're talking about Ossio, this specific product that we're talking about today, I've started using recently, is basically an alternative to metal implants. So Ossio is 50% natural mineral fibers, calcium, silica, magnesium, other things in there as well that kind of mimic bone, and that'll be important here in a little bit. And then 50% PLDLA that binds the fibers together, but that's gradually cleared by hydrolysis. So eventually, after about 2 years, the implant will dissolve and all that's left behind is bone. So what are the benefits of something like that? It's strong. It's 1.5 stronger than cortical bone. It turns to bone over time, so we don't have to worry about hardware irritation at some point, and no need for hardware removal. And the good news is if you put this in and you're not happy with it, you can either cut through it or drill through it. Have either of you had to go down that path? I haven't luckily had any issues with it, so I haven't had to try to drill or ream it out of there.
No, I mean, the nice benefit of the product clearly is it's, modifiable, which means that you can adjust the length if you need to maybe have something that's longer or shorter. You can adjust the length. And so that's what we do in surgery mostly. I've never implanted it and felt like I need to remove it. So to answer the question, no, but I do think that you have that option, which is another benefit.
No, I haven't either. And what you described, Jeff, is really the integration of the product. I mean, it's all about osseo integration. As it integrates into the bone when it's no longer needed, it's no longer there.
Absolutely. So, when we talk about strength, because that's the biggest hiccup I get when I talk to my patients about implanting a non-metallic implant, they have this misconception that it's not strong. Oh, well, that must be weaker. And so I have one in my office, I hand it to them and I say, try to bend it. And you can't. I mean, maybe the little tiniest ones you could, if you did, just like you could bend a K-wire and you could bend a thin little metal screw too. But the ones that I'm using, you try to bend it and it is significantly strong. So you can, take their word for it. They did these studies that looked at comparison of strength compared to the natural cortical healing bone, as well as comparison to peak implants and then the conventional bioabsorbables, and it's been shown to be stronger. So anytime I hand that implant to the patient and say, go ahead and bend it, then they try to bend it and they say, okay, yep, go ahead. That makes a lot of sense to me. We're going to avoid metal implants, no hardware removal. It's going to disintegrate over 2 years, and it seems to be pretty strong. So this is an animation here that's showing the osseo implant, resorbing and being replaced by bone naturally over about 2 years. And they've shown that after about 2 weeks, there's consolidation with the surrounding bone. So it almost starts to grow to the bone, which is obviously not something that metal does. Metal, if anything, there's a little osseous resorption around the foreign body implant. This has a little bit of the opposite effect where it starts to integrate with the surrounding bone and start to be stronger. So here in a minute, we're going to get into some cases. I thought that it was just important to kind of set the stage of what we're talking about before we get into the utilization of this technology and what it can do for us. So when we compare metal, PEEK, biocomposites, bioabsorbable, obviously you want to live in this zone up here where it's strong and has natural bone regeneration. So that's where osteofiber lives up there when we compare it to the other options that we have for putting implants into people. So all of the product line, and this is constantly expanding. There's new products coming out in the future all the time. This is what's available right now. We have these trimmable nails. They're in the top right up there, and those are impacted 243040. Then this is where these are the products that I love here in the bottom right, these threaded nails. What do you have a preferred, if you're going to do whatever, Lapidus, whatever it may be? Are you using staples? What are you using for your construct?
Well, I've had a chance to use all the products which are listed up on the screen, but my favorites are the staples. I'm a big staple person. I love the technology of compression staples. I've evolved through nitinol memory staples, and when you have a product like this that does the same thing, that can give you the stability that I want from a staple, and it just goes away after 2 years, it's just really a win-win for me and the patients. I think it's a remarkable product. I think it's probably something that I would use on a weekly basis. The others, I think, are as well very well engineered, and I think it's all about the material. It's really that, there's Me Too products in all foot and ankle companies. There's these products that we use for all foot and ankle fixation constructs, but it's remarkable that there's identical product in the material that goes away after 2 years. That's really, to me, the selling point of why I feel like it's the right option for me in many of my surgeries. And I think patients are very excited as well, as long as they know that we're not compromising stability and outcome, but that they never have to worry about it being something they deal with in the future. So that's my feeling, is the staples are remarkable, but the others also are very well engineered.
Luke, do you have a preference?
Just add a thought to that. I've been saying for my whole career that staples are the unsung heroes of foot and ankle surgery, and particularly midfoot surgery, for the close proximity of joints, the ability to come 90 degrees to the joints and not be trying to do oblique presentation, so forth, where you get stress risers to the joints like a Lisfranc fusion, midfoot fusion. So staples are just ideal and so easy to use and convenient. And then I just wanted to say, Jeff, on one of your previous slides about the strength question, this is, Tom and I have been dealing with the world of resorbable or non-permanent fixation since the late 80s in the residency in Atlanta. And people have been asking that question forever. How strong is X implant compared to everything else? And I always say it's the wrong question. It only has to be stronger than bone. It doesn't have to be stronger than whatever screw you've been using, stainless steel, titanium, this and that. The product only has to be stronger than bone. It clearly is, because its job is to successfully let the bone unite. And that's what's so cool about this. It's really the best sort of approach to let bone unite, fracture, osteotomy, until it's no longer needed, and then it resorbs and you're back to pure natural bone.
Yeah, I think these products are interesting because we all get approached all the time by reps with different companies who have a new screw, a new plate, a new this. This was the first time someone approached me, and I thought, oh, that's different. There's other bioabsorbable products on the market, but this was the first time I kind of stopped and thought, well, that makes a whole lot of sense. I'm going to look into that, because it's a headache for me to get new products approved at my hospital. And so I have to really want to jump through all those hoops to make it worth all my time and effort to go to the whatever VAT, I don't know, some kind of committee, and figure out if that's going to be something that they're going to let me use at the hospital. But this was one where I thought, yeah, this makes a lot of sense. Let's go ahead and try to get that approved and see how it goes. So this is an animation. It's not that different than utilizing any other fixation that we use on the market, especially if you're going to compare this to a cannulated metallic screw. You're just putting your wire in, you're measuring. And then the interesting thing about this is they come all in one long piece, at least with this threaded nail, and you just measure it and cut it to size and then implant it. So it's really slick. Do you guys use a saw? I just have a little saw on the back table, measure it out. It doesn't take much. It's just a quick little, it cuts easily with the saw, and you're good to go. Do you have any tips or thoughts? I use a little curved hemostat, little mosquito hemostat on each end. My nightmare is cutting it and having a piece of it fly off and end up, but the rep loves that. They're like, oh, let me open another one for you, doctor. So they love that. But I put a little curved hemostat on the ends of each screw there and make a cut. Anything different to add?
Right. Well, with these pins, they do come in a longer size, so you can modify the length, and that's really great. And you can use obviously one longer one in two pieces if you need a secondary point. So that's nice. The other screws are more finely measured to exact size. If you're going to try to cut one, clearly some people think they can just use a bone cutter, but I think that compresses it or squishes the central core of that. So I would just recommend the saw, like Jeff is mentioning. It just seems to be more clean. And you can cut it a little bit obliquely as well, and that gives you a little bit of a point to kind of place your pin into. It just has a central approach into the drill hole. So, yes, it's just as easy as that, really. It's nice to have that option.
So this part is kind of unique. It literally looks like a pencil sharpener, and I'm pretty sure it is a pencil sharpener. And so once you get done cutting it, in order to taper the end to find the hole a little easier, you stick it in this literally pencil sharpener and shave off the tip of it, and it kind of narrows the tip of it. I don't know. I don't know if that's absolutely necessary, but it takes off any kind of rough little edges where you've made your cut and smooths it out and just makes for a little better implantation.
It's phenomenal. And, that's the way to ensure that using appropriate technique, that you don't have any sort of subsequent issues from having trimmed it to size, right? And so that just makes it ideal for implantation. Just a quick anecdote with what you said, Jeff, about value analysis committees. The other big advantage here of this trimmable down to size is in your presentation to value analysis committees in your hospitals can be, listen, we don't need screws of every length, right? 12 millimeter, 14 millimeter, 16 millimeter, 18 millimeter, so forth. And the anecdote is 25 years ago, before this technology was here with an earlier generation of a product, I went to the hospital where I was on staff in Eastern North Carolina. I went to the Value Analysis Committee meeting because I wanted to get what was sort of state-of-the-art absorbable product into our surgery center. And the ortho spine guys had a list of things they wanted, and they're on the agenda. They didn't show up. And so they said, well, who's next? And it was me. And I presented this, and I talked about, listen, we only need one size. And they were like, you know what? These spine guys always want, each one has their own. I like 24, 26, 28 length screws. And the other ones, nope, I like 19, 21, 23. And those are some of the benefits you see all these years later with this trimmable technology.
Yeah, there's no gigantic tray that's holding 4 of each screw size. It's just a peel pack of that device, and then you cut it and shave it and implant it. And they're obviously able to be stacked on the shelf because they're peel packed and sterile, ready to go. So there's none of that sterile processing. The instrumentation kit, like I showed on that last slide there on the left-hand side, that's peel packed. So those are just ready to go. Yep. So I think this is probably the most interesting part of the presentation. I guess I'll let you guys decide, but this is Dr. Chang's what I used to do versus what I do now. This is how I used to fix things, and this is how I fix it now. So we're going to go through some of these just kind of quick fire before and after. You want to talk through, obviously we're looking at a hammer toe with these. God, I hate hammer toes, number one. And number two, I hate these little implantable things that bend and break. I seem to snap them or drop them. But you want to tell us what's going on here?
Sure. Well, I'd just like to start off by just sharing a little bit of our story because we both trained together. We're lucky to be able to be in Atlanta. But back then, we were already looking at bioresorbable types of options. We started seeing that with flexible pins at the time. And we had one of our residents go to Europe and bring back some early bioresorbable products. And
came back with a green screw. The green screw was a polyglycolic acid screw from University of Tampere, Finland.
Do you have to smuggle that in, or was that on the?
She brought it. Was Eileen Bashar. I think she brought it back in her purse.
But I mean, even back then, we were obviously trained in AO. We were using metal, and we use metal even weekly now. Metal's obviously been the standard of care. And it really is appropriate for almost everything we do in the foot and ankle. But even back then, we've looked at products that were in the resorbable category. And I think if this was a resorbable product, we wouldn't really be up here talking about it because all of those have come and gone because of inflammatory reactions, things that just didn't give us the best feeling long term. But this is an integrative product. That's really the difference. It's something that has adherence of bone to the materials as you place them, as Jeff mentioned. But over the next 2 years, the bone integrates fully through that fixation construct, and it's essentially gone. And so it's not an absorbing, actively inflammatory type of process. It's really an integrative process. And I think that's the difference. And I think because of that technology, all these screws, pins, staples that you've seen shown are really able to handle the same applications that we see with metal. For me, it's very important for me how it feels in my hand. And, I think we've all held different products, so we have to make sure that they really feel right before we place them in patients and think about using the technology. If you haven't felt the product, I would encourage you to do that. It's almost impossible. I've never been able to break one, and I'm very strong. And but
you can edit this, right?
Yeah.
No, but actually, what I will say, the poster child in podiatry for strength is one of my mentors in ACFES, Alan Ng. Al Ng is currently the president. I've challenged him to break it, and if you know Al Ng, and if he can't break it, then it's pretty strong. But for me, I have to feel that. I have to feel like it really makes sense to me with what I do and what I feel like I need. And this is what I have found to be absolutely, following those criteria. So everyone's used intramedullary fixation, I believe. We use K-wires internally, externally. Intramedullary devices, I think, are very common. But I routinely now will use the Ossio hammer toe implant. And that's the implant, I think, that Luke did the study on initially in Europe to even get FDA approval for us to use it in the States, right?
Correct. Myself and Yuri Stalk. Yuri Stalk's a great guy. He's a foot and ankle orthopedist in Slovenia. And he did 15 patients, and I did 15 patients in Vigo, Spain. Kudos to Ossio and their whole development team, Iran and Roni and Lior and the whole team. And, they took on this clinical trial. We were the co-principal investigators. And what's neat about it, I think, to understand is that they picked an anatomic area of tremendous applicability to foot and ankle surgery, right? There's so many hammer toes corrected every year. But also, and not many people realize this, we picked an area where there's a low cortical to cancellous bone ratio. So it's actually a very difficult spot to launch an innovative effort and be really, really faithful with, listen, we believe in what we've designed, and we're going to see what this result looks like. And the previous generations of non-permanent fixation always had the issue of a possibility of lysis around the bone implant interface, the absorption process, the hydrolysis process causing a secondary sterile abscess or quote unquote inflammatory process. And so picking hammer toe surgery as the clinical trial, where low cortical bone to cancellous bone ratio, this has got to work.
Yeah.
This has to integrate. And we have 3-year follow-ups on those clinical trial patients with MRIs and quantitative approach to the analytics of the MRIs, where there's absolutely at the implant, well, it integrates and goes away, but in the 3-year process or 2-year process, and then final the MRIs later, there's no inflammation, there's no signal change, fluid accumulation, and so forth. So that's what's really cool to me about not only the participation in getting it started, but the clinical application, which now you can roll on further, Tom, with how you've used that and then other applications. But it's important to understand where it started, because how many people have ever really studied hammer toe surgery and also had a company pay for the clinical trial, CT scans, MRIs on your hammer toes, right? and then, right?
Denied.
Right? 3 months, 6 months, a year, and absolutely be able to say, this works, and here, these results, and I'll stop here, mirrored the couple years prior of animal studies, okay, which had the histology and everything else. Obviously, you can't really get histology on human patients, right? But in animal models where, unfortunately, an animal gets sacrificed, a sheep or a rabbit down the road, and you can do histology. So anyway, it's just from top to bottom been super well done, and it's all real. Like I always say, histology doesn't lie. The histology can't lie.
Yeah. And I think that's an important, backstory of how this all came to be, because, you're trusting a company, and it's fantastic that they went through all those trials and you did all the trials and tribulations. And then we can get to the point where they put it in my hand and I drill a little hole and I put it in and we're good to go. Right. So all that back story and all that back research is super important to know that the outcomes are going to be safe for your patient and have good clinical outcomes if you're going down the path of recommending this, because ultimately we're only as good as our outcomes. When we have our patients sit in front of us, they are trusting you to make good recommendations, both surgically and with implanted hardware options, and they want to have good outcomes. We want good outcomes for them. They want good outcomes for themselves. So to have that reliability backing you up is obviously fantastic. So this is how you used to fix. I'm sure you've done 10,000 different little gadgets and gadgets and whatever Gazmos? That's not a word. Gizmos and gadgets. There it is.
Gizmos and gadgets.
Found it. Okay, so you've implanted this hardware previously, but then you started moving this BioIntegrative option here. So
right. The other thing I would just add is that the incredible aspect of Luke's study was that we could get MR images and look at this, cross-sectionally at 1 year and 2 years. And not that we never imaged hammer toes, but he did in his study. And when you look at these images at 1 year, 2 year, they're radiographically silent, which means there's no T2 inflammation, no white signal. There's nothing that is actively inflammatory, which is really what is much different than the other bioabsorbable products. So having said that and seeing that, I just knew that I could rely on that not to be a inflammatory negative factor in patients as they heal. So I only use these hammer toe implants now for all my hammer toes, even the lesser, smaller ones. I only fused 2, 3, and 4. But even for the fourth one, there are smaller medullary canals. There's the small size, which seems to fit very well into that joint. So it's been really my preferred option.
Well, real quick, excuse me, Jeff, go back to that picture if you don't mind. So, and look at the PIP joint on that second toe. It's indisputable. It's just 100% complete bone, right? There's no sort of implant looking. It's not like a pseudoarthrosis, but it's clinically stable. It's like you've got osseous trabecularization across the previous PIP, and there was a sort of dual stem PIP joint osseointegrative implant there.
I think would be really interesting is if you didn't prep the joint and you just put the implant in. Because in theory, if you didn't prep the joint, you have cartilage on the outside circumferentially in a ring. But if this integrated and was replaced by bone, it would still, in theory, fuse because the implant has turned to bone, even though you didn't take out the cartilage. Am I crazy to think that, or do you think it would still heal because of the way that bone would replace the implant?
No, I think you would see
I'm not advocating for not prepping joints.
I wouldn't. No, I understand the question, but I would advocate that you prep the joint still because that's just the approach. But I agree with you, Jeff. I do think that you would see bone cross across the scaffold of the implant, and that's what you want to see. So we can move on to the next one. This is just an example of a forefoot case, but whether it's osteotomy in the metatarsal with distal osteotomies, Austin's, hallux limitus, rigidus decompressions, fusions across the base and base wedges and lapidus fusions. If you're using screws, I've had the confidence of using screws and pins in a variety of different constructs for fixing these problems that I used to. If you choose to use metal, which I still do at times, I often now will fixate M1 to M2, from the first met base to the second, just to take care of that intercuneiform instability. Sometimes there's a splay there. It's an ideal application for an integrative screw because over time, as you bring that across, I've seen some bridging of bone from M1 to M2 right where the implant is, like you're talking about.
Exactly.
And that's something that is showing the integration of bone through that implant and that implant going away completely at 2 years. So I think that's an ideal option. And I've adapted using these similar implants to other joints along the central Lisfranc area that can see obviously 1, 2, and 3. We'll talk about a non-union case in a second, I believe. But, as I look at these patients that have arthritic changes through the medial 3 joints, I never fuse 4 and 5, but I do 1, 2, and 3 pretty routinely. And even patients that have a bad hallux valgus that have first MP, met cuneiform arthritis, a lot of times they'll have central Lisfranc pain as well. And if I need to do that, I'll do it all at the same time. When I do the central Lisfranc, like Luke mentioned earlier, it's ideal for staples. It's just a nice compressive, non-invasive, violation of the joint. You're just compressing joints that you prepare, whether you drill them, whether you graft them, you just have pure compression across there. So I use staples routinely for these 3 joints and maybe a secondary ancillary point of rotational fixation.
I just want to make one additional comment a little bit about, Jeff, your idea. I don't think it's a crazy idea, but it sort of dovetails with the intercuneiform stability or M1, M2 bases, where you were talking about, Tom, getting consolidation or osseous union there. When you think about the history of AO and internal fixation, you have to remember it's about stability. There's never been any sort of magical effect of compression on primary bone healing. What you really need is stability. And when you have, like, let's say you did that you didn't take out the cartilage, it would probably still work. But when you do take away the cartilage, you have more bony interface there, which just enhances the stability of that construct. In that sense, it's a PIP joint. Same thing back here in the midfoot, right? So if you put an osseointegrative implant across M1, M2 bases or C1, C2, it's stable. It's going to unite, right? So that's really the key. It unites. The implant osseointegrates, and you're just looking at bone.
Yeah.
Stability.
Yeah, what I would add is when you
that's
use
what staples do too, plus the compressive effect of a compression staple.
With these constructs, even if they have solid union with the metal components, many times I'll have removed these 2 and 3 because of prominence. As swelling kind of resolves, that just seems to be prominent more than other areas of the foot and ankle. And I've many times removed these post-implantation because of just irritation for patients with shoe wear. And you might find that if you use a staple dorsally, but I often trough the bridge of that staple on the bone, so it's really less palpable, but also it goes away in 2 years. And so that's another benefit to the fact that that prominence that patients might feel initially will resolve as time goes by. So it's another benefit of just using something that you trust to be strong, but also is not necessary to have any longer once the bone heals.
Yeah, these are great because if you're a mediocre surgeon like I am, you can't see how bad your throws were. That's my x-ray. Is it good or bad? We don't know.
You got to understand something here real quick about what this technology represents, particularly in the bone implant interface with a staple. You have osseointegration of the implant on the surface of bone, not intraosseous, okay? And that's never been done before, okay? Because a screw or a pin in the bone, that's one situation, but this is on the surface. And Ossio has histology from animal models of a plate on the surface of a bone, and the histology up to almost 2 years later, and you can see the plate incorporate histologically or meld right into the bone. And that's what the bridge of a staple on the surface of bone is doing. And so that really speaks to the technology because it's not just dependent on the intraosseous ecosystem or milieu of bone with the implant in the bone, like let's say here in the calcaneus. No, it's on the surface. And that's what the bridge of a staple is able to do. And that's just really, really cool.
So calcaneal osteotomy here, we used to use these screws. And even if you use a headless screw, I don't put my headless screw all the way deep just on the off chance I have to go take it out. I'd never find it again. So I do leave them a little bit proud. So you could argue that a headless compression screw is lower profile than these headed screws. But obviously having nothing poking out the back of your heel, there's not a lot of coverage back there. This patient on the right is going to be a lot happier than the patient on the left.
Right. But I never started doing this until the screw or the pin sizes were large enough diameter-wise to allow me to have stability. So this now is using the 4.5 and the 5.5 trimmable pins. And now that we have larger diameter options, then you can start doing these hindfoot cases that you rely on more of a thicker implant. The ones initially were for hammer toes, for maybe DMOs of the first metatarsal, some lapidus cases. Those are a little smaller. Now we have options with the larger sizes, and I know that they're coming out with even comparable sizes to a 7.0 screw in the next year or so. So that's exciting that we'll be able to do everything that we can swap into everything we're doing with metallic options now.
Let's move on to our next case here. Obviously, we have a hindfoot fusion here, multiple staples, big screw. I don't know how you think you're ever going to get that screw back out if you need to. But you don't need to when you do something like this.
Yeah, no, I've struggled with digging that screw out at times. Obviously this is buried, so it's not as common to take it out. But yeah, I mean, as I felt more comfortable with the larger options of the 4.5, 5.5 trimmable nails, it's nice to be able to adopt that to other hindfoot fusion applications, osteotomies and fusions of the hindfoot that we need these larger constructs. So routinely I would use staples for the TN. I use staples now as well with the Ossio product. And then I use at least 2 points of fixation. You can see the two coming from the bottom up into the subtalar joint. And these patients are non-weight bearing. Essentially I would keep my hindfoot fusions usually 2 months non-weight bearing. So I do the same for these osteopins. I don't treat them differently. I think the integration happens, but the fusion still happens at the same rate. So I feel very comfortable protecting them for the same amount.
That's a great point there. Let me just emphasize something. One of the, maybe Jeff, you realized this as you started to adopt the technology. A lot of people have the question logically, I've been doing certain things for 10, 15, 20, 30 years. What do I need to do differently now if I adopt this technology? And the answer is nothing. And that's what Tom's alluding to.
Right.
Other than being sure your technique is exacting, okay, because these are not, for example, self-drilling screws, right? So you do need to do the appropriate implant techniques. But other than that, you're not changing anything. And I think that's a sort of a stumbling block for docs initially. And everyone's busy in practice. People are calling on you. And so maybe you are like, someone might be reticent or hesitant. No, there's nothing else. You do exactly what you always did. And that's really important to understand. Also for you guys in the field, right? Sales.
Did you say, so we can see the staple in the bottom right there. You can kind of see the shadow of that staple over across the TN joint. Did you say that you're burring down the top of that to let it sit a little flush?
Well,
or maybe that's no different, but you can kind of see the top of that there a little bit.
Sure.
Yeah, go ahead.
I don't see that to be a problem with prominence, usually at the TN level because of soft tissue coverage. When you're more distal at the central Lisfranc's joint, like we showed earlier with those 1, 2, and 3 fusions, that area routinely seems to be an irritating area for metal fixation to be prominent. So I trough that routinely when I do central Lisfranc's. But even if I didn't, sometimes I've forgotten to do that because I felt like it sat fairly flush. That does go away and integrate, like Luke said, in 2 years. So that's another benefit that you don't have to ever think about that. But in this case, the TN joint, I don't go out of my way to do that.
Jeff, that was just mild technique error by Dr. Chang, and it won't really cause any negative consequence down the road.
No, it's just these little tips and tricks that people are probably, if they're going to adopt the technology, want to know how to get it in there. But I'll leave that between you guys. So this is non-union. I'll let you take this one, Dr. Chang. But midfoot non-union. Okay,
so this is just another approach that resulted in non-union. Nothing I did differently, but over the years I've found that these central Lisfranc areas are a little bit more difficult to fuse. I routinely would curettage and drill and pulverize through the subchondral bone, but sometimes that subchondral bone plate is very thick at this central Lisfranc area. So now I've resulted in not just leaving distraction and curettage, I just will resect away the subchondral bone. So that's my approach. I always graft that 2 and 3 when I do it. Some people do a trephine around there. That's kind of the same principle. They remove that subchondral bone plate and have the bone grafted, so they just have raw bleeding bone on both sides. So in this case, I had to revise it, and what I will do is I'll just go ahead and now resect the sclerotic bone that was obviously unhealthy. But even in primary cases, I do that, and I'll put a bone graft. You can see a bone graft there in between two, and the base and the cuneiform and the upper left. So that's what I do for any primary or revisional fusion, just to get away from that thick sclerotic bone. And then if and when you ever need to modify the length of one of your legs, you can just see on the central lower slide there that I cut a little bit of that arm because I thought it was needing to be just shortened a little bit. And that's your choice. I don't do that often, but you can. And then again, this sits pretty flush on the lower right, but If you wanted to trough it a little bit, you can also do that. But it's just remarkable. And once you release it from the inserter, it comes back to the pre-memory compressive state. So that these are just similar to nitinol compression technology. It's just engineered through an Ossio product. So I've resected. You can just see a little bit more of the resection. You see a bone graft centrally. And I'll just put the staple right over that. I usually use one centrally. It's a thicker diameter, so it's like 2.9 millimeters, and it really fits there well. The real estate sometimes doesn't give you more than one good placement, but you can secondarily put in adjunctive, secondary stabilization, trimmable nail if you want to. But, in this case, I just did that. We'll just move on because I know we're moving through this. This is another case with a revisional, hallux valgus that needs to be treated. It was recurrent, treated with probably not the best procedure.
That's not your correction?
No, not yet. Not yet. I think we can edit a lot of this. But the bottom line is
there won't be anything left.
Routinely, 2 and 3, sometimes with metaductus, if you visualize where you want to put the first metatarsal, you might find that you have to address metaductus as well. And I would routinely do that with 1, 2, and 3, and you'll see that. And again, when I do Lisfranc's, Lapidus, central Lisfranc's fusions, I routinely use the Ossio. I think it's remarkable, as like we showed with the staples and adjunctive fixation. So here you can see abductory wedges of 2 and 3, and then that will give me room to put 1 where I want. And you can argue that first could have been fused. Clearly, you can choose a first MPJ fusion, but the reality is that once you realign a joint that just happens to be in more congruous and better positioned, a lot of times that, inflammatory malalignment pain seems to be improved. We find that in the ankle. We find that with a lot of joints that we reposition and structurally realign, and sometimes that joint can go on to function for many more years. So it's just realignment and getting better positioning. But I routinely do midfoot fusions with the Ossio approach.
So this is actually one of my cases here. I threw it in here because it's something just I thought might be a little bit different. It's a proximal fibular fracture, Maisonneuve fracture with some increased medial clear space and a posterior malleolar fracture. And so this guy came into my office. It's obviously something that I'm gonna tackle operatively, despite the decent alignment proximally at the proximal fibula. That increased medial clear space, I'm not gonna let that fly. So I decided to take him in and try to stabilize a syndesmosis. And so when we have proximal fibula fractures, Maisonneuve fractures, that's what we call a length unstable fracture, which means it wants to slide upwards because of the nature of the proximal fibula fracture. You want to pull your length back and then keep your stability there. Most of the time, we're using flexible fixation devices, at least I am. I don't know about you guys, for syndesmotic repair in the setting of trauma. But on this case, because of the proximal fibula fracture, you want to bring that back out to length and maintain your stability. And so I decided to put these 2 screws across the syndesmosis. You can see that I did clamp that there. Normally, I don't use a clamp, but the reason I used a clamp was that I clamped it down and then I spun the fibular component distally to get some added length on it. And I didn't crank on the clamp because I do think you can overcompress the syndesmosis with a clamp. And then obviously any fixation device you're going to put in there is going to just maintain that compression. So you can overcompress the syndesmosis. But I clamped it, spun it, and then it kind of eased off the clamp a little bit when I implanted the hardware. But you can see here, I thought that when I stabilized the syndesmosis that I wouldn't have to do anything further medially. Luckily, one of the things, I don't know if you've been following along, but we just had a Gatekeepers Journal Club with Ryan Rigby. We talked at length about the deltoid insufficiency, medial malleolus, fixating, working from lateral to medial to stabilize your construct in the setting of trauma, which is fibula, syndesmosis, and then evaluating medially with stress intraoperative fluoro. And so once I got done stabilizing syndesmosis, I did stress fluoro. I could see that the medial aspect was still opening up with some talar tilt there. And I knew that I was going to have to throw some anchors into the medial malleolus. So another offering of Ossio is that they do have suture anchors. You guys have experience utilizing these suture anchors?
Yeah, I mean, routinely I would use them for reattachment of the Achilles, retrocalcaneal approaches. That's very common with anchoring. I've done PT advancements with the Kidner and whatnot. But I've used a larger Ossio anchor. I think they're 5.5 in terms of the drill hole for the back of the heel. The anchors now that are smaller available are 2.5, which is really a nice option. So for rostrums, for medial deltoids, for midfoot, forefoot, plantar plate repairs, there's a 2.5 option, which you might find attractive for those anatomic spaces. What's remarkable in this case for me, to just, it just shows you that even if you do a good fibular length, kind of realignment, you can do a syndesmotic repair and you feel like you have stability. You should really stress that ankle intraoperatively, like Jeff has done here, to just show you still have medial deltoid instability. And it can be a rotational stress. But the bottom line is, I would much prefer doing what he's doing now and repairing that instead of just leaving that to hopefully scar down in an appropriate position. Because we've just seen cases down the road where that was just left unaddressed and patients just have chronic swelling, chronic pain, and they're just not able to get back fully just because everyone just believed that every medial deltoid repair will be fine after you realign it.
Just a side comment is I think over the last couple of decades, in foot and ankle surgery worldwide, there's been a tendency with the anatomic specificity of implants to sometimes be guilty of letting the implants dictate what we do. And the reality, here's a great example. It's still the surgeon, your knowledge, your experience, and clinical decision-making that drives what you do here, stressing the deltoid intraoperatively. And the implants are just the tools that help us finish the job. I mean, we still have to make all the right decisions and so forth. But sometimes it's easy to think, well, we've got these new implants, and so I just do whatever the technique guide says. No, they're still just the complementary tools that help seal the deal.
Did you use the 2.5 anchors here?
Yeah.
Yeah, so it's remarkable how much smaller they are for these anatomic spaces. But you could argue for this, you could even use a larger anchor, but the 2.5s are strong enough for you to feel comfortable doing a deltoid repair.
Mm-hmm. I'm filming this with my super thick Meta glasses, which makes me look like Squints from Sandlot. You remember Squints from Sandlot? Okay, so this was then, I did dump that into an anchor in the medial malleolus here. That's what the picture is showing here. And then after I repaired it, it was much more stable. You can see the shadows of the syndesmotic repair system. And then I was pretty happy with my medial reduction there after implantation of the suture anchors. So just another utility of multiple different products, all from the same company. Because one of the downsides, I think, is my nightmare is trying to, well, give me that screw from that company and then call this guy because he's got the bone graft and then and then it's just 85 people in the room. So the more products that one company can have available for you, it's just less headache for me. I don't have to tell, oh, hey, I got to message this. I forgot to message that one. So just a kind of an example here of utilization of multiple products from the same company as they expand their product line.
Well, and over time, it's not a surprise if one of those screws would break naturally, right? If you use metal screws, we always see these syndesmotic screws break, whether you choose to remove them or not. That's really patients maybe specific in your preference, but you never have to think about a secondary surgery to remove these in the future. They probably will break, but they will integrate over the years that we talked about.
Plus, it's one-stop shopping, and you get to avoid that awkward dance in the OR where you got 2 or 3 different product reps, and they're all sort of like nudging each other for space around the table, and you're like, are you going to use my thing? Or...
All right, I'm going to pause for a minute. I'm going to have everyone in here leave because we need to get downstairs. We're going to keep recording here, but I'm going to have all of you guys go ahead and go downstairs so we can keep rolling with the afternoon. Thank you guys for joining us on Pod Patrol. All right, so let's move on to this next case here. We have this severe bunion deformity. I mean, that's just everyone's headache when they walk into bilateral too, when they walk into your office with such significant deformity there. What was your thought process on this case?
Well, it's an interesting case. I need to do hindfoot stabilization as well. And at the time that I used the Ossio products, we weren't able to do hindfoot, product for that because of the sizes available. So I had to address the forefoot, clearly a large bunion. I know that many times the first MP fusion by itself would reduce the IM angle in an appropriate manner, but because of how flat the foot was, I wanted to stabilize the medial arch as well. So I chose to do a double fusion. And so I did both the Lapidus and the first MP fusion. That was just my perspective on it. I'm not arguing that you can't do one or the other, but I did both. And with both of them, I used the Ossio products. I used staples on the first metatarsal cuneiform and then cross screws distally. And that's just how it came out. And I did the same thing on the opposite foot about a year later. But you can see here that I still chose metal for the TN. Routinely, I use, staples like we showed earlier and a screw for the subtalar. So anyways, nowadays, I have the ability to do everything with Ossio, which is nice. But and people have talked more about double fusions along the medial ray distally. And I think this is logical. I don't think there's really any negative with, locking up too much motion as long as you have good alignment and functional stability. I would be careful about fusing the IPJ, the Hallux IPJ. I think that's something you need for compensation more. But we all know the position of the first Met cuneiform and the first MPJ. If they're positioned well, they should function well.
I think this is fantastic correction. And I don't have a big problem with a double fusion because if you look at her preoperatively, she needs whatever you can do to get her into better alignment. I mean, that looks, we saw it on the previous slide, some of the most painful deformity and the existing deformity there just looks significantly painful. So have you had any issues with the double fusion along the medial column?
No, I haven't.
Which is really a triple fusion on the medial column with the TN.
Sure, yeah.
Correct, right.
You better hope her NC joint doesn't start to ache a little bit.
You better massage it and talk nicely to it so it doesn't
I'd be using
fail.
I'd be using some Voltaren gel on that, maybe 4 times a day.
Keep it happy.
We can edit that as well. But the MC joint and the Hallux IP are both able to compensate. But yeah, that's part of the conversation with the patient for sure.
Yeah.
Good. Yeah, that's a fantastic outcome. I mean, look at that clinical alignment there. She's got to be super happy with that. So as we talk about, expanding product lines, it's beneficial to us as surgeons to have everything we need with one company or, as few companies as possible, I think. But as we continue to advance and new products come out, larger screws, suture anchor line is expanding, and then potentially the idea of a plate construct is very interesting as well. And I think those are all in the works. And I think what you mentioned before about how the staple lays on top of the bone and then slowly integrates down into the bone is amazing because it's almost like a self-correcting prominent hardware issue. If you have prominent hardware that's metallic, that's never going to self-correct. But if you have a hardware prominence that's integrating into bone and smoothing out over time, and that's maybe a difficult discussion. You say, hey, wait 2 years, this will go away. But the good news is you can wait 2 years, and this should get better slowly over time as it integrates.
I got to tell you, of all the slides that I have, and Tom, we don't really have the physical slides anymore, but of all the lectures and all the material, I have to tell you, one of my favorite of anything over my entire career
is Pod Patrol. Thank you.
Yeah, there's
Thank
Pod
you.
Patrol.
Okay, all right.
is the histology from Ossio of the incorporation of the plate and the sequence of 12 weeks, 24 weeks, 48 weeks, onto I think it was 104 weeks, which is 2 years. Of the histology of seeing this plate on a long bone. I believe there was a sheep model, might have been a rabbit model. But anyway, just eventually going away. And I was like, that's incredible.
Yeah.
It's incredible.
It really is. Because that was one of my, when I was talking with them, I said, does then the plate or the screw, or the plate or the staple just become bone? If it's integrated with bone, does then that prominence stay bone? And they said, no, it slowly starts to kind of meld and integrate into the bone, which I thought was actually fascinating and not necessarily what I would have predicted. So do you guys have any closing thoughts about Ossio products or what we've talked about today?
Well, I just wanted to add that, this started as really a focus in the foot and ankle space, and it's grown obviously to all parts of the foot and ankle. But what's been exciting is other subspecialties of surgery. We've seen a lot more kind of media presentations now with orthopedic applications into tibial osteotomies, and we've seen hand cases being shown. We've seen some sports medicine cases in the upper extremity. We've just seen this technology used throughout the body, and other kind of very critically thinking surgeons have looked at this material, looked at the application that they need in their own, in their own hands, and they've trusted this product as well as Luke and I have also. I mean, we're only here because we would only want the best for our patients. I'm not going to have any compromise to the outcomes that we all want and our reputation that we've built over the last 25, 30 years. And I just know that this has given me the confidence to deliver the type of surgical approach that I feel I can be proud of. And I feel that way fully, because I wouldn't compromise that for anything else. So I'm telling you that this is something that I feel is worth looking at. I know other areas of the surgical, spectrum, other specialties have looked at it equally, and it's exciting to see their kind of acceptance of the material and also their applications throughout the body for other applications. So very much appreciate your time, just giving a chance to share some of our experience and cases. I think I've also been given so much confidence watching Luke and his work, back 30 years ago in Spain, putting in the first resorbable screws and growing since then.
Mm-hmm.
And I think we're at a point now where we've never been in terms of having material that truly is maybe the perfect fixation device. It does what it needs to do. It's stronger than bone. It allows bone integration and bone support as it's healing. Once it's done, it just needs to go away, or it doesn't have to stay around, and does that really within 2 years. So I couldn't be more excited about just sharing that with you and some of the things we've done with it.
I want to add, thank you, Tom and Jeff. This has been awesome, and congratulations on your form and your format and everything. It's cool.
Thank you.
I want to pivot back to something at the beginning, and it's give a shout out to the bench work that was done by the team in Israel, Ronit and Oran and the whole team, the basic science of this, because again, Tom just talked about very nicely sort of a wrap up of the practical application and with his cases and so forth. But there was even a talk this morning in the academic session about what are we putting in patients and the fact that it creates a, sort of a bioactivity response, right? The reality here is that the previous generations of this non-permanent technology always met with some concern about some form of bioreaction. I mentioned it earlier, but the basic science of what we're actually using in patients is incredible, because what Ossio discovered and made, their real unique contribution is, and you mentioned it, Jeff, the biodegradation process in the first couple of slides is a hydrolytic process, but it's an acidic degradation process. And so what caused foreign body reactions, when they weren't that common, but they definitely happened, is the acidic degradative products, which the body has a difficult time clearing. Okay, so it's like this bolus dose, and the body can't really clear it. And what happens here? The mixture of the absorbable component, the poly LDL, and the other 50%, which is mineral salts. What Ossio figured out was, as the absorbable component hydrolyzes, it's still an acidic process, it is neutralized by the incorporation of the mineral salts. And that's a basic process.
Sure.
And so what they did was they figured out biochemically the pH neutral integrative process.
They're smarter than I am.
They're really smarter than all of us. Okay. That's fantastic.
Yeah.
Because that's why there's no adverse side effects, even in clinical trial terminology. There's no adverse side effects or reactions and so forth. And what does all that do? It allows you the clinical application downstream as you scale any type of enterprise into customer adaptation, use, and satisfaction. That's why it's so cool to wrap it all together from the very beginning to today, right? So, hey, listen, thanks for having me. I know I sort of, jumped in here, but this has been really cool, and I'm grateful for participating.
Absolutely. So thank you guys for your time. I really appreciate it. This has been fantastic. This is the first live Pod Patrol episode I've done. So scrambled to get all the gear set up, and hopefully we'll see if the product stinks on the back end or if I hooked everything up correctly. But thank you guys for your time.
Thank you, Jeff.
No, my pleasure. Thank you.
Thank you, everyone, for joining us on this episode of Pod Patrol with your host, Dr. Jeff Dykes. We'll see you guys next time.
Disclaimer. Opinions expressed are those of the content creators and do not represent any employer or entity. The information shared is for informational purposes only and should not be construed as medical advice or used in any legal capacity, including establishing standards of care. All efforts have been made to comply with HIPAA regulations. No guarantees are made regarding the accuracy of statements or opinions provided. Interaction with the podcast does not establish a doctor-patient relationship. Please enjoy this podcast responsibly.